Welcome to HL7 Da Vinci Community Roundtable. Today's session is Dive into Performance Reporting for Value-Based Contracts. My name is Alex Goss, and it is my pleasure to welcome you to today's session and to remind all of us that we engage in these forums under the HL7 antitrust policies to ensure appropriate collaboration and information sharing. Thank you for joining us today. This September Community Roundtable is going to include two parts. The first segment will be a brief update on Da Vinci News, as well as some housekeeping items. And then we'll kick over to our primary event, which is the value-based performance reporting. As fee-for-service shifts to value-based care, value-based contracts have emerged as a mechanism that providers and payers may use to better align their contracting structures with broader changes in the healthcare system. To support value-based performance reporting for quality and risk contracts, one of our provider members proposed the value-based performance reporting use case to solve challenges around the lack of reporting format standardizations, the resource-intense process, lack of scalability, and complexities of data reconciliation. Our presenters today will introduce the use case, its genesis and scope, as well as inviting you, industry, to participate in the development of implementation specifications for value-based performance reporting. We have a terrific lineup of presenters today, and that includes some of the project leadership on this use case, including Heather Kennedy, Principal Interoperability Architect at Humana, Vincent Powell, Manager of Population Health Informatics at Providence, as well as Samira Singh, the Director of Population Health Informatics at Providence, and Teresa Yunkin, Project Co-Lead and HL7 Project Management Office Member and Senior Consultant at Point of Care Partners. But before we dive into that juicy topic, I want to go ahead and cover a few housekeeping items, some news, and events details. We are recording today's session, and we will make this recording as well as the slides available for you tomorrow on our Confluence page. As a result of wanting to post a quality recording, your lines are muted. Please use the question box in your GoToWebinar panel to send us questions. We will take questions after the presentation. We also have a few support folks who are going to help out our presenters, so they may be answering your questions as we go through the session as well. And we thank Michael and Dave for their support. If you're having any audio issues, suggest that you can use the dial-in number provided in your link, or trying to leave and come back can often resolve the issues. In typical fashion, we have a survey launch at the end of the webinar, and we really appreciate people taking time to complete that very brief survey to help us with future programming. Speaking of future programming, we have 2 more sessions for the rest of this year only. We will be convening on October 26th for Da Vinci program update. And I really want to help you understand that there's a synergy between the October 26th update and the November 30th update. Note that the November 30th is on the 5th Wednesday of the month, and we moved that to after Thanksgiving and canceled our December event. But between the October 26th and November 30th sessions, you're going to get a really awesome set of overviews that will help you understand our use cases, as well as and the progress we've made in 2022, but also our 2023 priorities. The registration details will be posted to the Confluence site in usual fashion. Upcoming events that we'd like to highlight for you. October 18th, our own Dr. Viet Nguyen will be presenting at a WEDI virtual spotlight series. So we encourage you to attend that session from 1 to 2 p.m. Eastern. On October 31st through November 3rd, NCQA Health Innovation Summit will be held in DC. And in January of 2023, yeah, we're planning that far ahead already. Hopefully you'll join us for the HL7 FHIR Connect-a-thon on January 14th and 15th, as well as the working group meeting the following week, January 16th through 20th. Both of these events are being held at the Hilton Hotel Lake, Las Vegas Resort and Spa in Henderson, Nevada, just 30 short minutes from Las Vegas. In regards to key news, we wanted to tout a few items for you today that are hot off the presses. advanced explanation of benefits, or AEOB, and good faith estimates, or GFE, for covered individuals has a request for information that has been released on September 16th by the Departments of Labor, Treasury, Health, and Human Services. They're seeking information and recommendations regarding the transfer of data from providers to facilities, to plans, issuers, and carriers, other policy approaches, and economic impacts of implementing these regulations. There are specific callouts for FHIR APIs and the efforts that related to Da Vinci's patient cost transparency use case. The full content of the RFI is available. We'll have a link on these slides that we'll post tomorrow. And comments are due by November 15th. So we'll do some internal collaboration with our Da Vinci members to prepare a response. Hope you'll take the time as well to consider the request for information and provide your thoughts and ideas back to our federal partners as they advance. No surprises in our billing. Additionally, from our Congressional Hill, there was an interesting movement this week on last week, on House Bill 3173, which is about improving seniors' timely access to Care Act. This is now moving its way through the congressional process or legislative process. It's going into the Senate, and we hope that they'll pass this. It's going to provide some interesting legislative language related to seniors receiving quality care under Medicare Advantage, with a heavy focus around prior authorization, and to improve the overall process and support some further policy work by our federal agencies, and clearly leverages, or can leverage, our burden reduction tracks for CRD, DTR, and prior authorization. Encourage you to take a look at that if you haven't already. Maybe you can coordinate with your legislative affairs folks. It'll be interesting to see how that progresses, because it will definitively impact our trajectory on burden reduction and prior authorization in the country. Further opportunities to get involved and influence include our weekly meeting schedule to tackle the open ballot reconciliation. We have 5 implementation guides that we're working to build consensus related to changes that were proposed, and got some feedback in the balloting process. So we have 5 separate sets of meetings. I want to make sure that folks are aware when these are happening throughout the next couple of weeks, and especially around PDEX, that will be pivoting from a noon time frame to a 2 p.m. time frame for that ballot reconciliation. And you can see the other schedule on the slide. So at this point, what I want to do is stop with the general information and dive into the juicy details related to performance reporting. I'm going to ask our first presenter to come on screen, and they're going to walk us through an overview of this newly crafted use case. So welcome, Teresa, as our first presenter. And you want to come off mute?
I came off mute.
All right, awesome. Thank you, Teresa. Take it away.
Awesome. So first and foremost, thank everybody for attending. This is very exciting for us, because we are a use case that is just starting and getting ready to go public. So this use case was first called into discovery earlier this year, when payers and providers put their hands up to collaborate and to work together. And they wanted to solve a common business problem, and they wanted to do something around value-based initiatives, because this is really where healthcare is starting to move to. So this moved from a brainstorming session to a formal use case discovery request to HL7, and that happened back in February this past year. And after the group met and did some preliminary discovery, there was enough interest and a resounding yes to move forward. So this use case was funded in March. Our formal discovery began, and that brings us to today, where we are announcing that the use case will hold its first public call this coming Monday, October the 3rd, from 2 to 3 p.m. Eastern time, and we'll cover those additional details at the end of the session. The team has been working on defining and refining the scope of this use case. So again, I'm Teresa Yunkin with POCP. My provider project co-leads are Samir Singh and Vince Powell from Providence. Our PHIR project co-leads are Heather Kennedy from Humana, Katie Rowan from Optum, and Dave Gandhi from Cambia. Our project co-lead from the vendor point of view are Michael Patwell from Edifex and Brent Zenobia from Novelis. Our implementation guide author is Jan Harris from Optimum eHealth. We are still looking for a reference implementation developer. If anybody wants to do that, we are happy to have you. And of course, we're always supported by our wonderful PMO and HL7 via Jocelyn and Holly. Next, please. So let's talk about the value-based care system. The ecosystem can be very, very different depending on who you are and what you do. So when we all agree, when we start to shift from talking about fee-for-service to value-based arrangements, the first is deciding what does value-based mean and what does it apply to, and who's responsible for what actions in these types of arrangements. And so we took the time to examine the different types of value mechanisms at play and what part of that value-based arrangement we were going to address, and we distilled it down to the heart of this use case, which is value-based performance. So when you hear the words value-based, you hear things like value-based arrangements and value-based care, value-based contracts, value-based cost, value-based programs, value-based performance, value-based payments. Well, like I said, as we distilled down what we were doing, we came to really understand that this was really about what value-based performance reporting is. And as we start to go through the use case, you'll see why this has become a focus for this particular group. So I'm going to turn it over to Vince, and he's going to talk about value-based, this whole value-based performance reporting from a provider's perspective.
Thank you, Teresa. So I'll give a quick overview of value-based care for those who may not be as familiar with it. Talk through our current process for receiving and processing these value-based performance reports that we receive from payers, and then some of the challenges with that process that will highlight the need for this new implementation guide, which we're really looking forward to. So for value-based care, at its foundation is a partnership between payers and providers to care for a contracted population and to share in the financial risk of that population. There's data that both sides have. So on the provider side, there's clinical information. On the payer side, some financial information. And it's through sharing that information, that data, that we're able to effectively manage this population of patients. Everything from trying to improve care, reduce costs, and really just get a better insight on how to move towards the triple aim within population health. So one key question with these value-based contracts is, how are they performing? Is it financially beneficial for both the payers and the providers? And the insight into whether it's beneficial or not and how it's performing or underperforming, those come about through these value-based performance reports, which is what Teresa was mentioning. And here at Providence, we have around 150 of these value-based care contracts. And so it's quite a big lift to take these reports that come in and ingest them. And so that's one reason why we're very looking forward to this new implementation guide, which will help us exchange it over FHIR. So to give you a sense of value-based care, can we go to the next slide, please? So for these contracts that we have, there are many different varieties, and each contract is slightly different. On the left-hand side here, you can see these category 1 all the way over to category 4. I'm not going to dive into depth here, this will be covered later on, but just as a high level, this shows the various ways that the risk can be shared. Everything from no risk sharing, which for on a fee-for-service model, all the way up to category 2, 3, and 4, where payments can be received for meeting certain quality targets, like patients receiving their cancer screenings. There can be payments from the payer to the provider around shared savings, meaning where if we are able to reduce costs, we can share in those savings. And then also some all the way to category 4, where you're more of a capitated model. So lots can go in there. Just bring this up here to say that for each of these contracts, they're all different. They all have slight nuances, but the goal is still the same, to share that risk, and through this partnership to both reduce the cost and improve the care. All right, next slide, please. So this diagram here is to show at a basic level how we process these reports. The payers, as the arbiters of the financial information, will send these performance reports on a regular basis. It could be monthly, quarterly, annually, to say how the contract is performing. They come in various formats, file types, and as the provider, we receive that data, and we want to process it. Put those into our SQL databases so that they can be reported on, so that we can compare contracts to with other contracts to see how we're performing, to see what's underperforming, dig into some of the reasons why. Some of the challenges with this, though, is that each report from each payer is slightly different. And as you can imagine, each organization has their way of naming metrics, has their own way of putting together reports, what they look like, how calculations are done. It's all slightly different. And even within each report for each contract that we're working with, those will change over time. There might be ways that the report can be improved, so that will change, and then that changes our process for then ingesting it. So it's there's no standardization around this. It's in the both the format, the name of the measures and all that within the file, and then taking that and ingesting the data is a very manual process. We have a team of analysts who full-time will take these reports. They will kind of do some manipulation so that we can say, okay, if it's called this one thing by these providers, we will need a common terminology so that we can report on, compare apples to apples. So we'll do that manipulation, that sort of massaging the data, and then ultimately load those into a database so that they can be reported across the board for our executives. So I guess in summary, the process, it's very manual. There's a lot of variability, and that can cause some errors in processing the data. And so with FHIR, we're really looking forward to being able to standardize and automate this process to have just a more streamlined process for getting the data in, making sure it's clean, getting it processed in a timely manner. And we just really appreciated the collaboration so far with the payers and the vendors and everyone that's been a part of this. And we continue to look forward to others participating in this process. We've done our best to pull from our knowledge and experience, but we certainly look forward to other perspectives to help make this a more robust implementation guide. All right, I'll turn it over to Samira.
Thank you, Vince. So I hope that throughout this presentation that all of you see that we're focusing on collaboration, right? Everything that we do is going to be a collaborative effort. And that is largely because success in value-based care is dependent on payers, providers, third-party intermediaries working together. None of this can be done in a silo. And so in these partnerships, well, this slide essentially demonstrates kind of the journey of value-based care and performance data exchange. So within this partnership, you typically have 2 or more parties that first negotiate what their contract is going to look like. And this would be your value-based care agreement, whether you have risk or not, whether it's upside, downside, combined, whatever it might be, right? You sit at a table with your contracting departments and you look at data to determine what kind of agreement can the 2 parties go into. And I would say that an important component of this process is 1, establishing your contract, but 2, also determining what type of data is going to be exchanged between the participants. It's important that we ask questions like, what kind of information, so what kind of data elements, what kind of fields need to be created, extracted, exchanged to create a complete picture of how well the provider is doing on their value-based care agreement. And also, we also have to ask ourselves what kind of data is needed to highlight areas for improvement. Those might be gaps as it pertains to closing out specific processes. It might be compared to spend. There's a lot of categories, I think, that will go into detail down the road, but really determining what kind of information needs to be shared to give us that holistic view. And I think it's also important that we recognize that step one is vital to this, but it's not part of the value-based care performance implementation guide framework, given that that requires that parties of different backgrounds come together and create their own process. There's that contracting component that you cannot necessarily automate. But next, the focus in the onboarding process is setting up and configuring the infrastructure to be able to support this data exchange. So in your legacy process that Vince just talked about, that may look like something like setting up an SFTP, which is your secure transfer process. That's pretty automated, right? You set up a server, you're able to exchange data, store it in your cloud or on-prem environments. That may have looked like perhaps getting access to a portal where you go in and manually retrieve data, or you agree to exchange information via email. Or perhaps you have some predetermined meetings on a quarterly or monthly basis where you get together and do a deep dive into the performance criteria with someone on the other side, whether you're a provider or payer. So in the new process, we're hoping it's going to be a bit smoother, right? But you'll have to ask things like, do you need a third-party intermediary to help you with this data exchange? There might be a product on the market that allows you to, with a flip of a switch, start getting down the road, your performance data for value-based care through FHIR in a standardized way with standardized elements with a common definition, right? You may have to decide whether you want to build the infrastructure yourself, so perhaps getting a FHIR server, or based off the number of contracts that you have, whether it makes sense to use something like Postman or a different product where you can go out and retrieve the data as needed in a bit more of a manual process, but it's whatever works for you. So that onboarding process is really important in determining what the framework, the infrastructure, the process is going to look like as it pertains to data exchange. And a lot of that is detailed through our IGs. And we're anticipating, obviously, it'll be detailed in this one as well. So after the infrastructure has been set up and tested, your providers start receiving their initial performance reports. Throughout the performance year then, you'll have your payers continue to aggregate the clinical data, whether that be through claims or other ways, other data exchange methodologies, and they'll continue to recalculate your value-based care performance information and make that available to you on a regular basis so that you have real-time data as a provider to be able to reach out to your members if needed, your patients, apologies, that you have the information that you need to dig in from an analytics perspective, that you have information you can share with your stakeholders that is timely. And that's a key component here. And then after this performance year is completed, that last step is the reconciliation process, right? To this point, the payer has received the data that throughout the year in terms of clinical data, and then they've received feedback from providers and they can reconcile all of that, give you a final report that shows how you performed for that given performance period. And we keep saying it's a performance period because we know that throughout those HCP land categories that Vince mentioned, your period may look like January through December. And it may start in June, it may be a quarter that you're agreeing upon, whatever it may be. So you receive your final reconciliation, your payment, if there is an associated payment with it, follows after that. And so this process essentially covers from after contracting to the final reconciliation that tells you how well you performed on your value-based care agreements. Okay, so next I would like to pass the virtual stage to Heather Kennedy, who will continue talking about our value-based care performance reporting journey, the associated IGs.
All right, next slide. All right, so as Samir just walked us through that process, we have already established our contracts, and now we're going to talk about how this is the continuation of the value-based performance journey that we have established. So if we were to follow the journey as the implementation guides exist today, you have already established offline your contracts and what performance relationships you have with your partners on the provider side of the house or the payer side of the house. And now you're looking to implement the exchange of data to support those performance metrics. So you probably have implemented Da Vinci member attribution, where you can give out the attributed members to your provider population and the agreed upon population that's going to be measured. You've also probably used data exchange for quality measures or risk adjustment to give the performance measures for what we need data for. And then we are probably working in a bi-directional exchange between those gaps in care and those risk measurements to actually receive the clinical data back using either the payer data exchange or the clinical data exchange IGs. So now that we've went through this performance life cycle, we're ready to finally say it's the end of the quarter, it's the end of the annual basis. We want to provide out how did we do. So now we can pull out the value-based performance reporting IG that's being developed now, and will be a public call soon, to actually start using that to communicate between the two on how we're doing on our performance metrics and what are the financial incentives tied to those. The value-based performance reporting is a bold because we focused on this use case with population level data to determine performance, and it's also extensible for other performance reporting IGs. So typically in value-based care, the first thing that comes to mind is usually data exchange for quality measures or risk, which is probably what this will heavily be used for, but it could be used for other reporting initiatives based on the contractual agreement. Very much to how Samir was highlighting, it's those data nuances that you have to agree upon in your offline contract out of band from this to make sure that it aligns with how you actually leverage this IG to report out. I'm going to pass you back to Teresa to continue the conversation.
Okay, there. Thanks, Heather. I appreciate that. And Samira as well. And as you can see, this is a very complicated relationship, and it can span over many payers and many providers. And so for us to be able to start working through this use case, we were like, well, we should probably get some kind of user story together and kind of put some assumptions around it, so because we can't boil the whole ocean, right? We can't do everything for everybody. So our user story is, as a provider VBR administrator, I want to view the status of my organization's financial performance to date as outlined in my contractual agreement with this specific payer. So we said, well, what does that really look like? You know, like in everyday, what is it? So your payer would generate a performance report for a specified period with your performance measures, and Samir and Heather both spoke to that. Then the payer sends this generated performance report to an endpoint that's indicated by the provider. And it was important that the provider have a way to determine how they're going to get the report. And so that, because there are concerns about security and where the provider wants to get the data to either receive it or to retrieve it. Are they going to pick it up right away? Is it going to sit there? So the two ways that we've really talked about this and framed it out in our discussions is that the provider can retrieve from the payer's FHIR server, so they can retrieve that performance report, or the payer can push the data to the providers, and then the providers can go and get the data when they're ready for it. And what's really important is that providers have the flexibility to get it when and where they're ready, right? So, and the very last part of that whole section is that the provider reconciles a payer report for the performance measures. Now, this is the first IG, so this is STU1, so we're looking at something that's not very complicated. You know, we want to make sure that we're doing this in steps and appropriately as we're moving along. The assumptions that we have put around this user story is that the reporting is on overall financial performance and major contract terms during that performance period. It's going to be based on production reporting from other programs. We're not doing risk adjustment calculations. We're not doing quality calculations. We're not doing any other type of calculations. What we're looking at is how the provider is performing. We're going to be looking at adjustments to payments that are based on financial reporting, not quality reporting. The risk prediction model information, if it is provided, is a part of the value-based contract, and so that includes that clinical and financial risk. So that's part of the contract. And our contractual elements were developed from the HCP LAN APM models. And again, VBPR is not, the value-based performance reporting is not dependent upon other IGs. So those are the assumptions that we went on as we started to work through the use case and what it looks like. So the performance reporting workflow, so as a visual, you'll see up here on the left-hand corner, again, both Samir and Heather really explained this well. Oh, I'm sorry, Alex. I keep forgetting to say next. On the onboarding and establishing infrastructure side, that's where you're going to be establishing those data agreements outside of the loop. But the first part of the process in any sort of value-based work is this knowing what needs to be built, right? It's super important, and it's included on the slide because you need to know what you're going to be doing. So are we trying to solve for the challenges that Vince mentioned earlier, right? We want to move away from each payer sending reports using proprietary formats. We want to unify naming conventions across payers. We want to move to machine readable formats. We want consistent report formats so that providers can ingest that data. We want to reduce the need for payer portals, and we want to make sure that that data can be automatically entered from the reports into internal databases. And again, we're talking about this as a population level performance. So as you look to the very top, you'll see that in the payer is going to generate performance reports, the performance reporting summary. Again, that's going to be at the population detail. We are not doing member level detail. So they'll send that report to the provider. The providers have to then reconcile that internally. Again, that's where Vince was saying, that's where a lot of the challenges start to be. And once the provider reconciles internally, they've got to provide feedback to the payer, and then it goes back up and we start the loop again. Then the payer gets the feedback, they apply it in however they want to do in their using their business rules, and then again start to generate new performance reports that get pushed. So it's an ongoing cycle. What's really great about this is that once we build this one time, when you build that onboarding and establishing that infrastructure the first time, you can scale. It can be reusable, and you can use it for other reports. And I'll talk about that next as we talk about what was in scope, out of scope, and some of the data elements that we identified were for this. So thanks, Alex. So next, let's talk about what we consider to be in scope and out of scope. So right now, in scope will be from payer to provider data exchange. STU1, in STU1, we're looking at, and why we kind of got to this point was that, right, if the provider doesn't meet all the measures to qualify, how does a provider know where they're at, right? Right now, what happens is that, you know, that providers get reports, and maybe it's, as Samira said, quarterly, it can be semi-annually, it can be annually, and you don't get a chance to see how you're doing so that you can improve your performance before the end of that calculation period. So one of the things that we looked at in scope 1 is, so how do we get that data? And it's just payer to provider. So in scope for STU1, we're looking at things like contract level. Is it at the clinic level, the organization level, or maybe it's regional level? We're going to generate a performance report and do that data exchange from payer to provider. One of the things that we also talked about, and I'm sure that you know, as we started collecting different reports, looking at them, data elements and all the different things and the processes that are involved with value-based contracting and value-based reporting, was that, you know, we could do a whole lot of things, and we really wanted to narrow down the scope. So we decided, you know what, let's bucket things appropriately. And so now we're into the future version. So maybe in a future version, we'll start to look at external or out-of-network reconciliations, maybe final contract settlement calculations, and that would include inclusions and exclusions, maybe some invalidations, CQL calculations. That's very popular, and we know that other IGs are using that. Any sort of QA process. Right now, we're not mature enough to do that. And maybe we'll start to bring in other alternative payment models, because these models do change year from year, depending on regulation, depending on legislation, and just depending on basic just market conditions, you know, depending on where you're located. One of the other issues that we thought about too, as we were talking, is that, you know, maybe later that we talk about things like splits and mergers, because that's a real thing, and we all know that there are mergers and acquisitions happening all the time right now in healthcare. So how do you work through those? So that, you know, we're going to parking lot those things for later. And out of scope, we really want to talk, out of scope is going to be anything that's like risk prediction at an individual member level data. So again, this use case is about population level, the aggregation of that population. It is not about individual individual members or patients. So, and that is kind of our in scope and out of scope for this particular use case. And next, Alex, please. Again, Vince talked a little bit about the HCP, the HBC land alternative payment models. And these are pretty very varied. And again, right, we start on the left here, we've got fee for service, there's no link to quality or value. And then we start to move over to the left, we've got category 2, where we've got some fee for service, some link to quality and value. Maybe you're engaging some case managers to help you manage your population. We're doing readmission quality measures, some of those things but we still have fee for service. Then we get to category 3, where we've got like these APMs that are built on fee for structure architecture, but we've got a lot of quality wrapped around in there. So we've got risk payments, but these risk payments aren't tied to any sort of quality measures. And then lastly, we've got that category for that population-based management, where everybody's at risk, and it's not really linked to the quality. Those are capitated payments. So capitated meaning that we've both decided that we're going to take some risk here. If we do good, we all do good. And if we don't do well, then we all share in the not doing so well. And as time has gone on over the past, I don't know, since 2008, 2009, we're slowly making these shifts, right? And healthcare is beginning to focus more on performing and measuring a high value activities when it comes to taking care of the patients. And that is a lot of the structure of what goes into these alternative payment models. And we're trying to help payers and providers kind of move our way from the left all the way over to the right. Next slide, please. All right. So this slide is very interesting. So I apologize, there's no legend on here, but just for clarification, when you see a green arrow, that means that there's upside risk, so it's positive. And when you see a red with a red dollar sign, not arrow, dollar sign, that is downside risk. And so if you're looking across this really is a comprehensive representation of the VBC ecosystem in US healthcare. And what I like about this is that as you move from the left to the right, you'll see that the risks and the rewards increase as you go across. So if you can remember in that category 2, maybe we're just doing care coordination payments, right? There's upside on that risk because of the fact that, you know, your patients are doing better, they're being monitored, we've got help making sure patients are getting what they need, where they need it. So it's positive for everybody involved, but it's a low amount of investment, low amount of risk to do that, like pay for reporting and pay for performance. When you start to get into pay for performance, you'll see that the upside risk gets to be more. We like to incentivize providers to improve their outcomes. As we move across to category 3, you'll see that shared savings, the needle starts to move up a little bit, right? So shared savings is when you're starting to participate in more complex arrangements. You've got provider risk, and you know, everybody's kind of doing a little bit on the upside. When you get to shared risk, that's when we start to see there's like incentives for the provider, and there's also penalties or reductions in reimbursements. Episodes of care is another one that it starts to move that needle over, where we're getting a lot of upside risk for providers. And lastly, that category 4, this is where we start getting those very complicated arrangements. So These help to cover those new admin expenses that you have, because it's not cheap to stand up risk arrangements. And then as you can see, you can go down, there's partial capitation, full capitation. As any payer knows on here, like this can get extremely complicated very quickly, involves a lot of negotiation and a lot of talking. Again, once we have these conversations and we understand these categories and the data elements that support them, it helps us to go back to the one slide where we had where it shows that complete workflow. Like that's where we're establishing our infrastructure. Thank you, Alex. Can you go to the next one? So our use case, one of the things that we want to talk about was the financial components, and they span over different contracts. And this slide gives you a little bit of information on how we decided to look at the data elements that we could include. Now, this is a preliminary working view of the data categories and the elements, and we wanted to set a focus when we start requirements gathering so that we can have the general public come in, and we really welcome your participation and your knowledge and the expertise to move this forward. It's really important that we have it. And I want to just talk about these proposed design categories that we've set out for the value-based performance reporting. And you'll see that if you think about those different alternative payment models, you'll see that the financial components, they can span a whole lot of different contracts, right? And so as we were thinking through the use case, we wanted to make sure that it could be implemented to fit a variety of different contracts, because so many of the data elements can be are covered in these different arrangements. And actually they do overlap. So as we start over on the left, we've got one bucket, and we're going to call that our contract details. So that those parameters would be things like trading partners, your participating entity, like what group is going to be in the contract, effective dates, covered populations. And as we get into the population pool funding, you'll see that we're talking about dollars coming in revenue. So premiums, allocated premiums, what comes in from risk adjustment, what comes in from other adjustments, carve-outs. And then as we move to the middle, you'll see that we've got expenditures, and we're looking at expenditures that are both current and target. So we've got total spend, target spend, medical loss ratio, MLR. I'm sure that you've heard that, and MLR targets, right? So these are some of the ways that costs that are involved in providing care. And then we've got a quality risk adjustment parameter where we've got current and target ones. So what was your quality actual, your performance actually? What was your quality performance target? What are your quality gates? And what are your risk adjustment metrics? What are you going for in your populations? And lastly, we've got earnings, which are the payment streams. So you've got your earnings max, earnings for quality, earnings for shared savings, and earnings total. And as I was talking through each of these parameters that are here that encompass financial performance, you'll see that I'm sure that like bells kind of went off and went like, yeah, like of course we're concerned about total premium. Of course we're collecting earnings, and it's not just for one value-based arrangement. It can go across many, right? Like you want to see your earnings that applies to government programs. It can apply to your commercial business if you're doing TPA. Whatever your value-based contracts cover, whatever lines of business they are, these individual data elements really do come into play. Next slide. All right, so we're very excited, like I said, before we had started our journey back in February, we've been kind of moving it forward, and with the help of of Jan, who's been absolutely amazing on this use case, we've taken the use case, and we're going through the HL7 process right now, and our primary sponsoring work group is going to be CQI, and we feel that like this is just a great fit for us because most value-based contracts, they include those measures for quality and risk adjustments. And this use case is also aligned with DEQM, risk adjustment, and those are also owned by CQI. So it's very exciting to be a part of kind of like that whole value-based family underneath the CQI work group. And then our co-sponsoring work group is the Payer Provider Information Exchange, which work group, and then we've got financial management as an interested party for this work group. We just really wanted to highlight that our payers and providers, they really do need a standards-based methodology to calculate the quality and the financial performance of a provider organization on a value-based contract, including but not limited to the parameters that I discussed on the previous slide. So this is kind of our where we are and where we want to move towards with this IG. And you know, you can read here through the whole scope that we had circulated and had gotten approval on. And again, at the very bottom, whenever it's applicable, we're going to be working with other FHIR artifacts, and we're going to utilize and reference work that has been done before, right? None of it's throwaway. Work with US Core, other IGs like DEQM, risk adjustment, member attribution, clinical data exchange, payer data exchange, health record exchange, and the list goes on. I am so excited about this particular IG because of the fact that, you know, this is, I don't know, I feel like it's a culmination of all of these different IGs that are coming together, and it really is an opportunity to kind of put everything to work and to move forward. Next slide, please. Let's see. Right now, as I said before, the PSS is going through the HL7 consensus review process. Again, CQI and PI work groups approved on September 21st during work group. Again, was extremely busy, and the TSMG approved it on September 21st. If you'd like to go look at the PSS itself, there is a link here that you can find it. It goes through the whole, the project scope and everything else that we've put together so far. And our reporting use case timeline, we're very excited about this. So again, if we want to work from left to right, we started discovery in Q2 of this year, and it went through Q3 in October. Yay! On Monday, we're going to open our community weekly meetings. That's again October the 3rd from 2 to 3 p.m. Eastern time. We'll start our requirements gathering in Q4. That's when we're going to be doing our gap analysis, starting to work on profiles and operational development. In January 23, we are going to be at the HL7 Connectathon as an information session. So we're really excited to talk about this. In May, testing at the HL7 FHIR Connectathon, and then again in July, testing at some Da Vinci testing event. During Q4 and July of 2023, that's when we'll start building that draft IG and doing the reference implementation build. We are looking forward to having many people here and connecting on the call to help us make this IG the best that it can be. Again, it's very complicated workflow, and we really need input from everybody from the community to come and to help us to make this the best that it can be. We'd like to ballot STU1 in September 2023, get some community feedback, and then our STU1, we're hoping to, it supports that payer-generated reporting and just sending it to the provider. And then after the HL7 FHIR Connectathon in September, we'll start ballot reconciliation, and then we'll start down our whole path. Hopefully we will be able to publish in Q1 of 2024, our first STU, and then the cycle goes on and on, as you can see to the right of the slide. Next slide. So I see that, so again, you can find all of the links here to become involved in this use case. We are on the HL7 conference call link, so you can go out to the link and make sure that you get signed up so that you get notifications of the meeting times and dates. The Confluence page is up in the public section. If you use the link, you can get there and see the work that we've done prior to now. Notes and meeting minutes are available there. And on the right, you can see the Zoom meeting information. This is also on the Confluence page as well. So we can get there. I see that we have quite a few questions that have come in.
We do. I'm really excited. I'm going to join you back on screen and also invite our other presenters to join us. I think I'd like to kick this off, if you're okay, with talking about the kinds of folks that you want to join this upcoming use case call, because this stuff does take a village, and we have different kinds of people in villages, and provider villages, and vendor villages, and payer villages. So let's talk a little bit about diving in deeper than some of your earlier comments about inviting folks, the kinds of people that you think would really contribute to the depth and breadth of this use case that you're building out, that you really want to work across those multitude of contract types. So I'm not sure who might want to weigh in first. Okay, go for it, Samira.
Happy to. So I think in general, coming from a large provider organization, I think we have resources that smaller provider groups do not. So I would love for us to be able to hear back from smaller provider groups. I think it'll give us a few things. One, a more realistic outlook on the kind of resources that would be required to be able to develop something like this. But also it would give us insight into the kind of value-based care agreements that are most prominent across the organizations in the country. I think payers as well, those that are focused on Medicare Advantage, on commercial, Medicaid, those that have government-based contracts, going into primary care first, historically CPC plus. The more people that we have involved, I think the better. Also for vendors who perhaps work with both payers and partners, or those who are implementing other IGs like ATR and CDEX and everything else within burden reduction, I think would be important, because you are in a lucky spot. You get to see how payers and providers react to the legacy processes, as I'm already calling them. And you have the benefit of being able to talk to both sides as well, both within this scope and outside, to see what is actually needed. Where the pain points are currently. I know Vince talked about our pain points, but I would still say that our pain points are pretty minuscule compared to someone who may not have an auto process to retrieve the data, someone who is looking to a portal all the time or waiting for those emails. So the more people, the merrier, truly, especially if you're calculating your measures a specific way, or everything is welcome.
Heather or Teresa, do you have any comments? I'm really also interested not only in organizational types and sizes, but also the folks inside organizations that we might want to think about that could really bring value into those complicated dialogues that we're going to have to work through to really get down to the nits and the gnats that make that implementation guide really hum.
Yep, I would encourage it, especially on the payer side and probably on the provider side of the house as well. Bring us your performance reporting experts, especially the data subject matter experts. Technologists are great. We can serve, and architects can serve. However, we definitely need the people who understand the nuances of performance reporting, I think, from any size organization at that. I'll pass that off to Dave.
You're on mute.
I hear one saying people that are familiar with the business process flows would be great. And yeah, people that understand standards and how they can be leveraged within organizations. So we produce an awesome product.
So technical, contracting, business, data analysis, small, medium, large. Teresa, you want to add into that?
Yeah, I would say medium-sized. I think sometimes those medium-sized payers kind of get left. They're not the super small ones, and they're not super big. And I think sometimes those medium-sized payers are doing okay, and they're chugging along, and they're getting things done. But this is an opportunity to kind of get ahead of the curve and really start to move. I know, because I came from a medium-sized payer. So like, this is near and dear to my heart. And then having people who really are socializing it across your enterprise is super important, because there are times when we need those boots on the ground people, those people who can define what this really means, who know business rules and processes that get applied to data as it comes into your organization. Those are the people that we need sometimes at the table to help us to answer those, because sometimes you get to a point where you forget what it's like to be in the trenches every day, like keying in data, and sometimes you find nuggets of gold in there. You know, it's kind of like the person who invented the cup holder for the stroller, right? Like we all knew we needed one. It just took one person to do it. And sometimes, you know, you have to be that person, or you have to engage people within the organization to come. And it's great to have technologists and business talking together, because that's how you develop really good requirements. Because people get what they need, and we can ask good questions, and we really get to the heart, and we come to a meeting. And as Samira said, that's where collaboration really happens. Dave?
I would extend that one step further. If you need help to socialize this within your organization,
Yep.
All of us have done that, and ask for it. We have a ton of help in that space.
Yes.
I think it's a really unique opportunity, because the use case is going to formally launch this Monday, 2 to 3 p.m. Eastern time. I encourage you all to come, because it's going to be great for you to, I know it's probably last minute if you're putting it on your agenda or your calendar, but you can start to track the Confluence page, and you can get in on the ground floor and really influence that, because there's going to be a lot more business-oriented discussions early on to figure out how to get the tech to work to meet the needs of what people are really experiencing. And so sometimes it's a little hard to jump into the middle of a use case that's already a team that's already humming, but this is a ground floor, folks, for you to get in on it, and I encourage you to join it. Any other comments on who you should invite to the table before we move on to the next session?
This is extremely specific, Alex, but if your organization has an actuary who is focused on value-based care, one, that is just an absolutely phenomenal skill set. But two, given that these individuals are always looking to the future, I feel like they can help us collectively develop something that is not necessarily predictive, but going in that direction, more real time, more, you know, just staying ahead of the curve.
I second that, Samira.
Right. And if they love data, this is the place for them. All right, so let's go ahead and take some of the audience questions that we've received. I'm going to start out with the first one, which I know some of these questions may have also been answered in shorthand through the response box, but I want to take a little time since we and unpack these answers. So we received questions about, have you seen payer use of portal-oriented products to present accountable care organization, or ACO, performance in more of an online manner rather than office type files? Does this approach help, or does it just create more payer specific engagement? Samira, you want to maybe give a first pass at that, or Vince?
Sure, I'll talk really fast, Vince. I'm sure you have way more detail on this, but I'd say that our experience has been that portals are definitely better than email. Let's throw that out there. Things get lost in email all the time. But with the goal of automating everything to reduce errors, to reduce burden, to just help speed things up in general, we found that portals are difficult because a lot of them do have an MFA component. And if you're looking to automate through, not to name specific companies, but through automation tools, MFA really puts a stop to that. Right, and then there's this other component about having to change passwords frequently, being prompted for that. And then also just the setup in general. What we found is that if you're going through a portal, there's usually a specific person within an organization that gives you access to that. Sometimes that changes, and then all of a sudden you've lost your access, you're not getting reports for that month. It's just, it's not the worst thing in the world, absolutely not. But it's also not very automated. And given that our goal is automation with little error, I'd say that it's not the worst thing, but not the best. Vince, please expand. I'm so sorry.
Yeah, definitely, totally agree. We have a number of payers where we use their portals to log into the website to try to retrieve the data. We tried using robotics process automation to retrieve that, to save a lot of man hours on retrieving those reports. But anytime a website changes or a password change is required or anything like that, it was just breaking the process, and so it just simply wasn't worth it, the investment of time to get that set up. So they're helpful, like Samir said, from a security perspective to get that information, but it doesn't reduce the time it takes to retrieve them, as well as it doesn't resolve any of the issues around like a standardization of the reports, or be able to automate and like streamline the process to get that data into an internal data warehouse.
All right. Next question we got, is there any reason this couldn't be addressed on a more frequent basis than what was mentioned, in the sense of we were talking about quarterly and yearly, just sort of as contract period, performance period kind of references generically. I'd like to see your thoughts on whether this could be done on a daily or a weekly basis. And Dave, maybe you want to kick us off with that?
Great. So I responded in the text that the more standards are used across the landscape and these processes can be automated, the more frequent these interactions can occur, from going from currently a monthly or possibly yearly interaction now to essentially real time, if full maturity, where we can deliver actionable data to help the provider better manage the patient's care. Yes, so there's no reason why this couldn't be much more frequent.
And I think
If I can
somebody,
add on.
oh, go ahead.
I'm so sorry, Alex. I wish there was like a raise your hand option. But just to add on to that, I would ask for the providers who are considering getting this data more frequently. I really like what Dave said in terms of member outreach. It's important that you have the most up-to-date data. But I would ask, how often do you believe that you need the data in order for it to be truly actionable? Because if you're getting it daily and you have a contract that has 20,000 members and you've only worked through, or you can work through, a small percentage of that for outreach, or you're only able to ingest that data into your data warehouse to feed it into analytics processes once a week, is having data daily really going to help? Perhaps your processes are very lean and you can do this on a weekly basis. You can automate outreach, you can automate analytics. You have executives who are extremely vested in this and they're looking at the dashboards on a regular basis. Weekly sounds really good. But for us, what we've found is that maybe perhaps bi-weekly or monthly gives us enough up-to-date information for those processes, but also doesn't put the burden on us to where we cannot ingest and normalize and standardize and disperse everything to the affected parties.
If finding that sweet spot's important, so I want to hear the payer side of the house. So thank you, Heather, because I want to see what is it from to generate the data from the payers is one side of the coin, in addition to how can it be used.
Right, so it's a cycle. So like we walked through for the value-based care journey, right? So you send in the clinical data to address, that data has to be aggregated, and not all payers, small, medium, and large, have the same capability of aggregating that data as frequently as we would love to. So some might be daily, some might be weekly, some might be monthly, some might be quarterly. Most of that is defined in your contracting period. So you'll say, we agree contractually that we're going to update this quarterly. And very much to Samir's point, you only have so many engagements during that quarter to actually have that member touch point. So the data's still got to come back to the payer. It's got to be aggregated through a grouper engine, and the insights have to come out before we can reproduce that and provide it back. Now, I think depending on how many payers you have, you might have the luxury of having some reports daily or some weekly. It just kind of depends on that payer engagement, because not all payers have the same level of capacity to provide those outcomes real time.
Anyone else to comment on that? Okay.
Standards, implementations.
All right, so next question. Oh, go ahead.
Oh my gosh, I'm on a roll. I was going to say, I do love that Heather said the clinical data component as well, because if your reports are dependent only on claims and you're getting claims daily, you're adjudicating all that stuff, that's one thing. But a lot of these reports are also dependent on supplemental data, whether that be your connection to a provider's EMR and you're extracting it yourself, monthly supplemental data that's sent through some sort of process like CDEX, right? ASMs, they're additional coding data to be able to close gaps. There's so much that goes into that I feel like even if you had a payer who can, just flip the switch and generate a new report, I feel like there's so many things that are kind of dependent on each other in that process that you might not be getting data that's as meaningful if it's too frequent.
And I think you're also showing the value of bringing a broader team to the start of the use case, because these are the kinds of dynamics we have to think through to really write a useful implementation specification that gets us to that standardization that Dave mentioned. The next question that we got, it's going to be a little bit more technical, and I'm not sure to what degree we're ready to really answer this one, but I think Dave's going to probably help me out with it, and maybe Michael, if he's still got audio, he might join in. So understanding that the IG is under development, is there any insight into what resources from other implementation guides, such as CDEX, Clinical Data Exchange, or Data Exchange for Quality Measures and Gaps in Care, will be utilized, or architecture to support the reporting expectations?
And I'm assuming you mean FHIR resources when you say resources? To answer that, I would say, so the use cases, for example, CDEX is about clinical data exchange. We would use CDEX to transmit any known data from the provider to the payer, and as a utility function, not necessarily something that's hard set in stone right now for CDEX. For member attribution, it's pretty well defined. There's a coverage and whatever's in there now, we would use the full IG as is. Data exchange for quality measures, it would be the general use IGs, or the general resources that are identified in the implementation guide for gathering quality data and delivering gap information. So we don't really know the exact details of the resources and IGs, but just generally that's what they'll be like.
And I think it's really great that we can base a lot of the development off of stuff we already have been working with, because it's the Fast Healthcare Interoperability Resources Standard on which we're basing these implementation guides. So there will be built-in commonality. But to your point, Dave, I believe there was a slide that showed that the gap analysis from business requirements to FHIR resources and profiles will really be a part of the work that will be taken on early in the development cycle over the next year.
And I'd like to jump in here too, because this is why it's perfect for anybody who's been working even on any of these other IGs to come to the table. Because I'm a part of the PMO, I get a chance to go to different groups, sit in and listen, and there is a lot of collaboration, and there's a lot of aha moments that go from one IG to another IG. So having people who've already walked down this road come and be a part of it, as well as who understand this ladder architecture, to come and to join now, as well as new fresh eyes coming in, is why this is such a great time to get involved if you haven't been involved before in Da Vinci, because you really are at the core and you're getting like all the good stuff. So that's my plug.
Yeah, I agree, Teresa. Now I'll answer for Jason. He's on my team and he has all that experience with the previous IG. So he will be joining us starting on Monday now that this is going public.
Yes.
Thank you. We're glad. Michael, as you may have seen, he's a part of the vendor co-leads on this team, and we're grateful he could join us because he is in the hurricane path today. So thanks for chiming in there, and thanks for the question from Jason. So we did have a question about whether this would be recorded, and yes, just to confirm, it will be recorded and posted tomorrow along with the slides. Going to check and see if there are any other questions out there for us to answer today, while maybe the panelists can also think about any thoughts, parting words, putting out there any particular challenging topics that you think you'll be diving into early in the launch of the use case. I have one general question. In the sense that there are a lot of payers that will get value out of this, as well as the providers, do we think that this is something that might get some regulatory traction for uptake at some point? Or do you think that it'll just naturally evolve under a proof of concept for being adopted?
We shall see. Huh? there's so much there. There's so many aspects, so many exchanges, and so much work to do. Let's do it.
Yeah, I would agree with Dave. We have so many different programs that are out there that, you know, we've already got legislation and regulation around government programs, you know, so we've got people here. We've had, during the discovery process, we've had some of our federal partners kind of join in and listen, because it is important. And, you know, if you want to be a part of an APM, there are contracts that have to be signed, data agreements, and having them at the table just to hear what's going on is great. But also, you know, just a note that there are so many already value-based arrangements that are contracted through other like government programs. So I think that whole piece, I've got my fingers crossed that maybe something good will happen.
Right. And prior authorization is a great example of what can come out of these work sessions.
Yeah, I definitely think it fits under the burden reduction. So I think what we're doing here for the industry is going to be acknowledged.
One of the things that I've seen over the 30 years that I've been working in this field is the transformation of the payer and provider and vendor community to leaning in now to developing standards and deploying because there's value and they make sense. And I think this is one of those use cases, regardless of whether or not we think that there's going to be regulation. I think it's going to get uptake because it's a point of burden and friction, and that we've really been working very hard to eliminate that as a part of the Da Vinci Project. And I also think the project has had an interesting opportunity to really foster new relationships and bonds across the aisle between the provider and payer and with the vendors in the mix of that community. And it's really great to see the leadership and that has happened here, because a provider said, hey, I want it. And then when we advance a use case, we need to have a payer and a provider partner agree to take that on within the Da Vinci community. And we didn't just get one, we've got multiples. And I think it's really fantastic. And thank you for your leadership, especially for this team who's really been leaning into that trust and transformation for the benefit of the humans. So I always like that. I'd like to call on Jocelyn Keegan to see if she might have a question. I think she's in the ether here and is queued up to ask us a question.
Yeah, and so I want to maybe tie a bow on part of the conversation, because I think that sort of where we ended with the Q&A, I think is really important. First, I am so thankful for the group of people that are on screen and that are behind this work. You know, I think there's a few things that have happened here. I think this team in particular has been able to ride the rails of a discovery process that we've been honing for 5 years. And you can see the output of that, right? We've got a really well-formed business problem. I'll give a shout out to the Providence team. Samira and Deepak, her boss, have been trying to get us to start this use case since they showed up at Da Vinci about 2.5 years ago. So we're finally excited that we found you friends, and people are catching up on understanding why it's important for us to digitize this information. But I think that what you're seeing in front of you, I think for the community and sort of this macro puzzle of how all of these IGs do fit together, and you can hear sort of the excitement in the voice of the folks that have been involved in this work from the beginning, is we're really allowing industry to drive here, right? You as organizations are coming forward and figuring out how things should fit together. And that what you're seeing, and you heard Teresa allude to, is our colleagues in the federal agencies are allowing you to do that and really following your lead and providing really important alignment where we need that to make the industry move forward. And I think we've moved from a position of, you know, we don't want to be regulated to how do we leverage regulation as alignment and encouragement to move towards standards. And that might be a controversial statement, but I think because of the strength that's happening, and you know, we have payers, providers, vendors sitting on a call talking about how they're developing willingly standards to do this work. And so I think it is really a nice capstone, not just for the work product that the IG is going to focus on, but also sort of the methodology and the community that we've built. And Da Vinci isn't alone, right? We're doing this across accelerators and really within FHIR, it's enabling us to do this. So I'm thankful for everyone. And like I said, the queue up of this use case and the move to public has been so clean and ready in a way that maybe we slid across the start line in prior use cases. So really excited to see the rest of the community start to get engaged and move forward. This is a fun use case, and you guys are kicking butt and doing a great job. Thank you.
appreciate the recognition of this strong team. We have no more questions in the queue at this point, but what I would like to do is ask for final thoughts and remarks before we wrap up for today. We got
More fun than the merry-go-round, huh?
Well, I'm going to put this slide back onto the opening up to the public in case people wanted to grab that really quickly, as well as knowing that I'll put the slides out there tomorrow so you can pick it up from there. Also, Leslie's put the link in for the VIPers, I want to call it, the VBPR use case. But any other comments, Michael, Samira, Teresa, Heather, Vince?
Doesn't this look like a fun group to be involved with?
Very much is.
You will laugh a lot. That is guaranteed.
I'll jump in and I'll say if you're implementing member attribution or data exchange for quality measures or risk adjustment, this is probably your next iteration. Why not get in on the ground floor on Monday and start iterating through so that you can finish your life cycle of reporting rather than having them sign out to another tool to get the reporting.
A really good point.
It's
Great
excellent.
promotional piece.
Was CDEX and ATR included in that, Heather? Because I think those are important.
Yeah. Yes, thank you.
And the clinical data exchange, CDEX, is so important for so many different purposes of carrying the payload of clinical data. It's getting a lot of traction for multiple problems that we need to solve. So,
Yeah. So I encourage everybody to show up on Monday. And if you can't make it on Monday, come on a Monday. So we are meeting every Monday. So hoping that we'll see some new faces this Monday and subsequent Mondays after that. But this really isn't important. I mean, at the end of it all, right, it's really about patients and it's about our members. And this is just one way that we can be a part of the whole moving healthcare forward and making sure that patients get what they need, members get what they need, because it's not just names and numbers that come in. These people are our families, and we're doing the work to help our families get better care and be better. So it's a useful use case. We see it all the time, especially if you got aging parents. You know, they're in some sort of value-based arrangement. So, you know, be a part of the changes that you want to see. Come join us.
Yeah, Viet also noted in the question box, if you haven't started your organizational FHIR journey, the time is now. Don't be intimidated, jump in. This is a great way to do it and get engaged and from the ground floor. So really good thought there, Viet. Thank you for sharing that in the question box with us. So I think at this point, I'm seeing that Matt Schuler has his hand up. I'm not sure if he has an additional question or not. Maybe he can type that in for us. Okay, maybe he took his hand down. Okay, we're all set there. All right, so with that said, wanted to thank all of our presenters for the time and energy to really put together this use case, this presentation, and for your energy and positivity towards making healthcare better in the United States. So thank you for everybody. And the hands up was actually an applause. So thank you. We'll have to get some better expression of support in our meeting platforms. I hope everybody has a great rest of your day, and we look forward to you completing the survey and joining us at the next Community Roundtable on October 26th. It'll be the first of 2 sessions that will give you the overall view of our program progress on use cases, as well as our trajectory for 2023 and the other use cases that we're going to put into our stable of standards. So we look forward to seeing you back in a month's time. Take care, everybody.
Thank you.
Thank you.